The one common thing that these many mechanical hip problems will lead to is eventually arthritis. The basic premise with hip arthritis is there's damage to cartilage. Cartilage is this, so all joints are these two bones that fit together, sometimes really in a very conformed way and sometimes less so. But the cartilage creates this smooth surface on bones that allows them, with the joint fluid, to move with very low friction and move smoothly. When the cartilage of those surfaces is damaged, we call that arthritis. But you can imagine, if you have a big or a small joint, the amount of cartilage damage and the location and the implications of that cartilage damage can vary greatly. So hip arthritis is a very, very broad term that can mean many, many things. When we see somebody or when we're thinking that this is hip arthritis, we first have to define, where it is and how much damage there is and how much is that affecting somebody's life and their activities and how much pain is that creating, and then what is the best way of dealing with that and fixing that. If somebody's dealing with hip arthritis, it will cause varying degrees of hip pain. Hip pain is typically felt in the front or to the side of the hip joint, the hip area, the flexor crease of the hip, down the thigh, sometimes to the knee. Sometimes it can be more in the back, posterior around the buttock area, but generally it's more front and side type area. Pain from hip arthritis can vary. It can be super sporadic and not very often, or it can be much more generalized and be accentuated with activities. Typically, weight-bearing activities are the ones that cause these symptoms to be worse or accentuated. Rotational type movements, bending movements of the hip. But then there's residual pain after you're active, so night pain becomes a big thing. And then oftentimes when people's sleep is affected, it's the time when they actually seek care, But generally, that's the type of pain that hip arthritis will cause. I've talked about a number of mechanical hip problems that all can cause damage to the hip. The one common thing that these many mechanical hip problems will lead to is eventually arthritis. So when your mechanics are off in the hip and you lead an active lifestyle, or you suffer an injury or an overuse type sporting event or whatever, those mechanical things and the damage that they create compound or multiply, the damage increases and eventually leads to what we will term hip arthritis, so the damage of cartilage of the joint. And when it becomes really significant, it will affect the normal spacing between the hip bones, so the femoral head and socket. The normal space that's created by that cartilage on an x-ray when you're standing will diminish if that cartilage is thinned or absent. And so we can see it quite frequently on x-rays once things have gone to a certain point, or we have to rely on more sensitive tests like MRIs, which will look for arthritis or cartilage damage in more specific areas before, spacing of the joint is diminished or decreased. And so, the diagnosis is made by first listening to pain and examining and looking at movements and restrictions in movements and positions that hurt, and then doing x-rays and typically MRI and so on, sometimes CT scan in unusual cases. But that would be how we would diagnose arthritis. Being diagnosed with hip arthritis is not a life-threatening condition. It can be life-threatening if you allow that pain and discomfort and dysfunction to diminish your activities and lead an unhealthy lifestyle. But when we talk to people and counsel them on how best to treat this arthritic condition, and we start to discuss the surgical options, we try not to make it you don't need to do this right away or else type situation. We're trying to explain to folks that this is, first of all, the condition you're experiencing. This is this is the pain you would expect to experience from this, either this much or maybe slightly less with this type of non-surgical treatment or more over time. And then put in perspective what the surgical treatment is and what that would mean for that condition. And then we try to come to a treatment strategy together. We try to figure out the best strategy for treating this together. It may mean fixing this and surgically fixing this right away, or it might not, and one of my most gratifying things is to see somebody with hip arthritis and have that discussion with them, and then have them go off for a year or two and just manage it on their own and alter their lifestyle slightly, but still stay active and stay healthy, and then come back in a year or 2 or 3 and have their hip replaced or fixed, and then go on to the next chapter of an active life. Like, that's one of the funnest patient interactions ever. And that happens to me now a lot because I've been at this for 20 years plus years. And it's really, really good. It's a very, very good thing. Being able to say to somebody, look, this is your condition. You have hip arthritis, and it can be treated either now or later. You decide. The option will be there. And that's very nice. That's great. So once we've come to the conclusion that hip replacement is the appropriate treatment for a condition, this hip arthritic condition, there are many different ways we could do this, and many different implants we could use, different approaches. It's been really fun for me now doing this type of hip surgery for over 20 years to see I don't know, maybe every surgeon feels this way, but I feel like we have come a long way in the past 20 years in the evolution of how we're doing hip replacement. The implants are better, they're more reliable, they're lasting longer. There's a big technological change that happened about 10 years ago with the bearing that changed that. But the approaches have evolved a lot over the past 20 years, and I've been lucky enough to be a part of that just because it was my focus. There are many different ways of getting to the hip. You can approach the hip from the back or the side or the front or medial. There are many different ways, and there are pros and cons of all of them. What I've settled on for my hip replacements for the majority of patients now is the anterior approach for different reasons. So when I came here to Seattle, I was looking for an approach that would eliminate some of the big complications or reduce the risk of many of the complications that I saw as a training surgeon. So of the complications or problems that can arise after hip replacement, dislocations are a big one. And by not damaging the back structures of the hip, the capsule and the musculature in the back of the hip, we've greatly reduced the risk of dislocation after hip replacement. So that was one of the big reasons I started doing anterior approach. What we've also found with this approach is it's much less painful to patients. It hurts much less than any other approach. This is not an easy approach to learn. It's not an easy approach to become familiar with or comfortable with, particularly for some of the more difficult hip problems. It's a very technical approach. It's been described for decades, but for me, it's become my main way of approaching the hip to do these types of procedures. And it's enabled us to become much more precise with the positioning of these implants. I basically perform this procedure with patients on their back during the surgery. I can bring in the small x-ray, what's called a fluoroscopy machine, to check position of implants and leg lengths and various important things in real time. It's also enabled us to do this very invasive procedure and cause way less pain than it used to. People would have a hard time imagining what it used to be like, obviously, if they've never had a hip replacement 20 years ago. But the level of pain that we're causing now is so much less than what we used to the point where we can actually provide this care in a setting where we don't have overnight stays. And that's and it's not like we just one day decided to do this in a surgery center. It's been an evolution over the past 20 years. So we started out having patients for multiple days in the hospital, and it just became less than multiple days, and then one night, and then no nights. And this is not appropriate for every patient, but for most healthy patients with not terribly difficult technical problems of the hip, being able to send people home the day of surgery is a remarkable evolution of this procedure. And I've witnessed it in real time myself with people, and it's been super fun.